Review of urinary and fecal incontinence. A 48-year-old woman you treat for multiple sclerosis presents with urinary urgency and incontinence. She also has sudden urges to defecate leading to fecal leakage. She notably has had multiple vaginal births. Her symptoms have caused significant distress. Urination and defecation are controlled by the autonomic and somatic nervous systems through the spinal-bubospinal voiding reflex pathway and the pudendal/splanchnic nerves, respectively. Incontinence results from injuries to these pathways. Urinary sensory input is provided via pelvic and hypogastric nerves to the pontine-micturition center. Parasympathetic inhibition facilitates bladder filling by relaxing the detrusor muscle, while the somatic S2 to S4 nerve roots constrict the urethral sphincters. Voluntary voiding control involves the prefrontal cortex, insula, and the periaqueductal gray. Incontinence symptom types such as urgency, frequency, or retention depend on localization within the nervous system. Suprapontine lesions lead to detrusor overactivity, resulting in increased urgency or frequency. Infrapontine/suprasacral spinal lesions can also cause detrusor overactivity, but also causes sphincter overactivity, resulting in retention. Sacral or infrasacral lesions result in inadequate detrusor contraction strength, also leading to urinary retention. Specifically for our patient, multiple sclerosis affects white matter, brainstem, or spinal cord tracts, causing uninhibited detrusor contraction. Urinary incontinence management begins with non-pharmacologic treatments, like scheduled voiding and/or pelvic floor exercises to strengthen bladder control. Anticholinergics or beta-3 adrenergic agonists can reduce urgency. Additionally, botulinum toxin injections into the bladder muscle offer relief for overactive bladder symptoms. For medication refractory cases, sling procedures for stress incontinence, artificial urinary sphincters, or sacral nerve stimulation are available. Bladder augmentation or urinary diversion may be considered for severe cases.
For defecation, autonomic nerves control the sigmoid column, rectum, and internal sphincter, while somatic nerves control the external sphincter. Voluntary defecation control starts in the prefrontal cortex. Defecation begins with peristalsis, moving feces towards the rectum and building rectal pressure. That pressure stretches smooth muscle, sending afferent signals to spinal cord nuclei. Efferent signals are returned through the splanchnic nerves, simultaneously contracting the sigmoid column and rectum while relaxing the internal sphincter. The pudendal nerve receives voluntary input from the prefrontal cortex for external sphincter control. Specifically for our patient, multiple sclerosis affects spinal cord nuclei, disrupting internal anal sphincter relaxation. Managing fecal incontinence starts with antidiarrheal drugs like loperamide to enhance stool consistency and reduce movements. Fiber supplements such as psyllium or methylcellulose increase stool bulk. Non-medical options include pelvic floor exercises and hydration. Sphincteroplasty for anal sphincter repair, artificial anal sphincter implantation, or sacral nerve stimulation to activate pelvic muscles are reserved for medication-resistant cases. Other surgical options include antegrade colonic enema surgery to create a direct pathway for enemas, or colostomy to reroute stool through the abdomen. Urinary and fecal incontinence are wide localization differential. Appropriate management strategies require neuroanatomical understanding. Our patient can first try pelvic floor therapy or medication. If ineffective, more invasive options like bodily touching injections or surgical interventions like sphincteroplasty or sacral nerve stimulation may be needed, as she may have weakened muscles secondary to plaque burden from previous MS flares, or injured nerves related to her history of multiple vaginal childbirths and a hysterectomy.
For more information on urinary and fecal incontinence, check out the course resources. For more information on this and other neurologic conditions, please visit aan.com/NeuroBytes.